Good afternoon, everyone. Thank you for joining us today. My name is Melanie Paris, and I'm the Senior Director of Health Initiatives and Education here at the American Kidney Fund. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the section of your control panel titled Questions. We'll see your questions and we'll do our best to answer them either by replying to you in the questions box or out loud during the end of the presentation. This webinar is being recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. As a friendly reminder, for those of you who are health professionals, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Today's presentation is about the transplant evaluation process, waiting lists, and how to prepare for a kidney transplant. Our speakers, Dr. Macy Henderson and Dr. Fiza Naqvi, have dedicated their careers to helping individuals with kidney disease navigate the transplant process and all that comes with it. Dr. Macy Henderson is an assistant professor of surgery and nursing at Johns Hopkins University. Her research involved the health outcomes of kidney disease donors and transplant patients. As a national expert in organ transplant policy and through her dedication and service to the National Organ Transplant Network, Dr. Henderson actively develops policy and guidance related to the donation and transplantation of organs from living donors to recipients in the U.S. and serves on the board of directors at the Organ Procurement and Transplantation Network, United Network for Organ Sharing. Dr. Fiza Naqvi is an assistant professor and clinical instructor at the Department of Medicine at Johns Hopkins. Amongst her many contributions, she has set up monthly teaching and educational sessions for transplant coordinators about the basic principles of kidney transplantation. Dr. Naqvi also aided in the establishment of a transplant clinic in Bethesda, Maryland, allowing for the evaluation of potential kidney transplant recipients from the DC and Virginia regions. She serves as the lead transplant nephrologist at this clinic. Thank you, Drs. Henderson and Naqvi, for joining us.
Thank you so much, Melanie. I am looking forward to going through this webinar and hearing from our listeners. I'm really hoping that through our webinar, we're able to educate our listeners and help the potential patients and their caregivers learn more about this process and hopefully navigate their way through to a successful transplant. So I am going to talk first, and Macy is going to join in later. So as we mentioned before, this webinar is focused on learning more about the transplant evaluation process, learning more about the waiting list, and how to generally prepare for this journey. So kidney transplant, next. Kidney transplant is the treatment of choice for late-stage chronic kidney disease, which is also referred to as CKD, or end-stage renal disease, also called ESRD. For most patients, a kidney transplant can restore a healthy, productive life. But one thing to keep in mind is that the effects of long-standing kidney disease do persist in patients despite transplant. What this means is that transplant is not a cure for kidney disease. However, it can vastly improve your quality of life and it can extend your life. According to the United States Renal Data Systems, the prevalence of chronic kidney disease or CKD in our population is approximately 15%, so a pretty huge number. And based on the last statistics, there are approximately 700,000 patients who have end-stage kidney disease. Next. So clearly, there is a huge discrepancy between the supply and demand. Deceased donor kidney transplants have progressively increased to approximately 12,000 transplants yearly, We have about 5,600 living donor kidney transplants that are done every year. However, there are more than 100,000 patients waiting for a kidney transplant. So this is a huge problem. I'm going to start off by talking a little bit about the function of kidneys. So next slide. So what do kidneys do? They make urine and they maintain a fluid balance, meaning they prevent too much fluid building up in your system. Kidneys remove toxins and waste products, which is a very important role that they play. They maintain chemical balance in the body. Kidneys help control blood pressures, maintain good bone health, and help make red blood cells or prevent anemia. Next slide. So patients with kidney disease will often hear the term GFR. GFR stands for glomerular filtration rate, which is a way of measuring kidney function. When your GFR or kidney function drops below 20 mLs per minute or 20%, that is when you qualify for a transplant. Ideally, it's best to avoid dialysis altogether and hopefully get a transplant when it's time. So when you avoid dialysis and get a transplant right away, that is what we refer to as preemptive transplants. And for this to happen, patients do need to be referred earlier. We recommend that a referral can be made by your nephrologist or your primary care provider, or you can self-refer as well. But this should be done once the kidney function is starting to get below 30 mLs per minute. Now, why transplant? And what's the major difference between transplant and dialysis? So most patients in the United States, when they are on dialysis, they undergo what is known as in-center hemodialysis. What that means is that you are on the dialysis machine, getting your treatments about 3 to 4 hours, 3 times a week. So while this process is efficient in getting rid of waste products, but you can imagine that for the vast majority of time during that week, you are not on dialysis. So this is the time when waste products build up in your system. So regular dialysis only provides 15% of less waste removal of what 2 normally functioning kidneys would. As a result, patients on dialysis can often feel unwell. They can feel fatigued. They can often have problems with cramping. On dialysis, blood pressures may drop, which can make them feel poorly. Patients can suffer from numbness and tingling in extremities known as neuropathy. The longer you stay on dialysis, there's concern for progression of heart disease, bone disease, sexual dysfunction as well. Patients can also be dependent on others for physical, emotional, and financial assistance. And the important thing to remember here is that the longer a patient stays on dialysis, it leads to higher risk of complications and higher mortality, higher risk of death later on. What I want the patients to understand from this is that yes, it's ideal to avoid dialysis altogether and get a transplant. But even for patients who are on dialysis, the sooner we're able to get you a transplant, ideally within a year or 2 of starting dialysis, better it is in the long term. So a study that was done a few years ago basically compiled the data from 110 studies that had been done on nearly 2 million patients. And they found that kidney transplantation is associated with a lower risk of mortality, lower risk of cardiovascular events or heart disease, heart attacks, etc., and a better quality of life. When we talk about transplant, we have the option of a deceased donor transplant or a living donor transplant. A deceased donor transplant can be what we refer to as a standard criteria transplant, meaning when a patient gets evaluated for a kidney transplant and they're told that their name, so that they will be put on the standard waiting list, that's what the standard criteria transplant is. There are certain other options out there, and I'm going to talk about them a little later. It's important for our listeners to understand that when they go through the transplant process, there are lots of different terms that are thrown at them, and it's important to try to understand them now and also inquire more and question the team when you go in and see the specialist at the transplant center, because these are terms you need to understand because they can potentially increase the donor pool. So something that I am going to discuss a little and just a little bit is a high KDPI list. KDPI stands for Kidney Donor Profile Index. And also PHS, increased infectious risk. PHS stands for Public Health Service. Again, these terms I'm going to go through in a little bit and try to hopefully explain a little better. When it comes to living donor transplant, the donor can be someone related to you, or it could be someone completely unrelated. It could be a friend, could be a friend of a friend. That oftentimes doesn't matter. And when you go through the evaluation, there are things that will need to be looked into. But if you have someone who's interested in donating to you, they don't have to be related to you. At times when we are not able to make a transplant happen between a potential recipient and donor, there is also something called paired kidney exchange. Again, something we're going to talk about in a little bit. Next slide. So a common question that we get asked is, how long will a transplant last? So this is a very difficult question because there are many, many different factors that determine how long a kidney will last. And there's also a very vast range of kidney transplant survival. So when we give estimates to patients, either at the time of evaluation or later, that is only an estimate, definitely not anything that's certain. When we talk about a deceased donor transplant, the half-life of a deceased donor transplanted kidney is about 10 years. For a living donor kidney, it's about 15 years. Just to kind of, this is a difficult concept to understand, but what this means is that from all the kidneys that are functioning, approximately half of the kidneys will stop working at the 10-year mark. Or for the living donor transplant, it means that half of the kidneys are expected to stop working at the 15-year mark. Now, I'm going to go through some of the terms that I had mentioned earlier. Again, the Kidney Donor Profile Index is a term that needs to be understood because when you come in for an evaluation, the transplant team will explain to you what this is and then ask you if this is something that you would also like to sign up for. What is KDPI? Basically, it's a term, it's a way of estimating the quality of the kidney. It's a percentile ranking going from 1 to 100%. How is this calculated? Well, based on the donor's age, their height, weight, ethnicity, whether the donor had any history of hypertension, diabetes, did they have hepatitis C, what was their kidney function, etc. Based on these multiple factors, all of these factors are put into a calculator and helps us come up with a KDPI score. What needs to be understood is that lower this number means longer the survival of the kidney transplant compared to other kidneys. So for example, if a kidney has a KDPI of 20% or a kidney donor has a KDPI of 20%, it means that this kidney is likely to function longer than 80% of the recovered kidneys. So meaning it's a good kidney. So lower the number, longer the survival of the kidney transplant. Next slide. So with this slide, I hope to better explain this point. What you see in the green bar represents the half-life of a living donor kidney. You can see it's close to 12.5 years. In the blue, we see the lifespan of the deceased donor kidneys, and they're divided up into 3 different groups. The first group, where it says KDPI 0 to 20%, that's the low KDPI group. Right on the extreme right, you have the KDPI 86 to 100%. That's the high KDPI group, and the one in the middle is the middle group. And you can see that there is not a huge difference between the half-life of a kidney that comes from a living donor compared to the low KDPI less than 20%. One's 12.48, the other's 11.44. So these match pretty closely. Now, if you compare this with the high KDPI, the bar, which is on the extreme right, you can see that the lifespan of this kidney is much shorter. So why would one want to sign up for a high KDPI kidney? Well, it increases your donor pool. So this may reduce your waiting time on the transplant list. These sort of kidneys are generally considered appropriate for patients who are older than 60 years, or those patients who cannot withstand dialysis for long periods of time, or patients who are not expected to have a very long survival. And I'm going to talk about this in a little bit in my next slide. One should also know that these kidneys, the high KDPI kidneys, if you do decide to sign up for one because you want to increase your pool of kidneys, you should know that these kidneys are biopsied before they are transplanted. And only if the biopsy of the kidney seems suitable do they proceed with the transplant. Next slide. Another term that you may come across while going through this process is EPTS, or Expected Post-Transplant Survival Score. Now, what does this mean? It means that the recipient, the patient, is given this score, and this helps determine how long that particular patient will need a functioning kidney for, meaning how long is that patient expected to live. Basically, so how is this determined? Based on age, a history of diabetes requiring insulin, the patients who require chronic dialysis and who've had a number of prior transplants. Based on these factors, a patient will be given a score, an EPTS score. Lower the score means that the survival of that patient is expected to be higher than average, or for example, if someone with an EPTS score of 20% means that they are expected to live longer than 80% of other patients. So the low KDPI kidneys, if you remember that as we discussed before, are the kidneys that are expected to last longer, are allocated to patients who have low EPTS scores or patients who are expected to live longer. So oftentimes the low KDPI kidneys will be given to patients who are younger, who are expected to have a long lifespan. Next slide. Another term that you should expect to hear is increased risk donors, or PHS, Public Health Service increased risk donors. So this is a separate list that you can opt to put your name under. Again, if you're interested in increasing your donor pool and hopefully cut down your waiting time. These donors are donors who are classified as increased risk, and 1 in 5 donors is now classified under this category. What factors lead to a potential donor being classified as increased risk donor? It involves the donor's sexual activity, so more promiscuous sexual behavior will put a patient under this category. Anyone with a history of intravenous drug use, anyone who's been incarcerated in the past year, etc. One should know, though, that the kidney survival and patient survival with these organs is no different from the other list, at times even better, because oftentimes a lot of these donors are younger with no medical health issues, and these organs work wonderfully. All of these donors undergo testing prior to transplant to check for infections, which is the biggest concern. The tests that are available now, they're known as NAT testing or nucleic acid testing. They're better than older tests in the sense that they become positive very close to the time of infection. So if a patient has something like hepatitis or HIV, this test should pick up the vast majority of cases. The risk of transmission of infection is very low, approximately 1 in 1,000. Next slide. So benefits of a transplant are that you will have an improved quality of life without the need for being hooked up to a machine multiple times a week. It improves your lifespan. It reduces morbidity or complications. However, one should remember that there are some risks to the transplant. It's a major surgery that you undergo. You are going to be on medications which suppress your immune system, and that's for the rest of your life, which puts you at risk for serious infections, potentially serious infections, as well as cancers. Not all patients are suitable for transplant. And when we evaluate patients, we look at the risks of transplant versus the risk of not receiving a transplant. And important to know that each transplant center does set its own guidelines for transplant. Not to say that the guidelines vary significantly, but there are centers that may not be comfortable transplanting patients who are older than, let's say, 70 or 75 years of age, and there are others who may. So there are these differences, minor differences that do exist. And when you go in to be evaluated at a particular transplant center, they will hopefully make that clear to you at the time of evaluation or soon after if for some reason you're not considered a good candidate at that transplant center, which also then means that just because one particular transplant center, if they feel that you're not a suitable candidate, doesn't necessarily mean that a different transplant center will think the same. I would not want to generalize this, but that is also something to keep in mind in certain cases. Next slide. Choosing a transplant center, there are some important considerations from a patient's perspective. Distance. While you can always be listed and evaluated at any center in the country, you should know that distance does matter, because even after the transplant, you will be expected to stay close to the transplant center for a period of time, and then after the transplant, the best thing for you would be to be followed at the transplant center where you were transplanted. Insurance matters. You should know whether your insurance will cover your evaluation and listing at a transplant center. Experience of the transplant center also matters. How do you go about finding a center? There is a resource that's listed right there. You can see the OPTN website that's mentioned here. To obtain data on the various centers, the SRTR website is an excellent resource. SRTR stands for the Scientific Registry for Transplant Recipients. Next slide. So what the SRTR website provides is data to compare the outcomes from different transplant centers. It will give you information on the number of transplants ever performed at that center in the past year. It will tell you what were the one-year outcomes for those transplants. What are the rate of transplant, meaning for the number of patients who are waiting for a transplant, how many patients actually were transplanted. So this information is helpful. It is not necessarily very simple, however, because you have to take into account that different transplant centers have a different mix of transplant recipients and donors. And while outcomes for one particular center may look better than the other, but you should also look to see, well, how many transplants were performed at that center. Some centers which are busier do more transplants, they do more challenging patients, so the outcomes may vary. So this is not so cut and dry, but it is a good resource to give you some idea. Next slide. For the transplant evaluation process, on the day you come into clinic to be evaluated at the transplant center, you'll meet multiple members of the transplant team, the nephrologist, surgeon, a social worker, nurse coordinator, potentially a dietitian. You will undergo your evaluation, which means that all of these various people will come and meet you and talk to you and get information. Then you'll be expected to get some tests, some blood tests, including figuring out what your blood group is, tissue typing, checking to see if you have what are called antibodies, which are proteins that some people may have as a result of pregnancies, blood transfusions, etc., which can sometimes make matching you with a potential donor challenging. So this is something that you test for, because not everyone has these antibodies. So that'll be something that's tested. You'll be asked to undergo some heart testing, an EKG, likely a stress test, and an echocardiogram. Other tests like chest x-rays, you'll be asked to undergo screening tests to check for cancers such as colonoscopy for those who are older than age 50, pap smears, mammograms for women. You'll be asked to get updated on your immunizations, and you will also need dental clearance. Next slide. At times, there may be some other tests that you may be asked to undergo. For example, CAT scans or CT scans. If there are any concerns, you may be asked to undergo what are called lung function tests or pulmonary function tests. If there are concerns for things like emphysema, COPD, asthma, 6-minute walk test is again not a test that everyone goes through, but could be asked from you. Ultrasounds, brain imaging, you may be asked to see a heart specialist, a cardiologist, a neurologist, etc. And some of these tests do need to be repeated annually and others not so, but this is all something that will be explained to you after you undergo your evaluation. Next slide. There are some conditions that could prevent you from getting a transplant. For example, if there's any severe uncontrollable condition which limits your life expectancy to less than 5 years, if there is either an active or an incurable cancer, if there are ongoing recurrent infections which have not been treated any sort of serious heart disease or serious vascular disease, which is hardening, calcification of blood vessels, severe liver disease. However, in that case, a patient could be considered for a combined transplant. Next slide. Important things, if there is history of non-compliance, serious non-compliance, which is recurrent, meaning patients who are missing a lot of appointments, missing dialysis, this can definitely go against you because it's important for us to know, given transplant being such a limited resource, that we're giving the kidney to the best potential patient. Any history of uncontrollable psychiatric condition or active substance abuse of note, prior history of substance abuse or a psychiatric condition that's now controlled is not held against you. Anyone who has limited or irreversible rehabilitation potential, that can also be a problem potentially. Next slide. HIV is no longer considered a contraindication to transplant. So if your HIV is well controlled, the virus is not detectable in your system, and you're on stable medications, there's no reason why you couldn't get a transplant. Age is not a barrier. Again, as I mentioned, certain transplant centers do have their limits to who they would transplant, but extreme of age is not considered a contraindication. Cognitive or neurodevelopmental delay, again, not a strong contraindication if we feel that there is adequate social support and the patient will be able to, either the patient would be or the caregiver would be able to help with transplant management. That's not a contraindication either. Next slide. So selection process. So after we gather all of this information, the entire transplant team sits down at least once a week in most centers, and they will go through all the patients that they saw in the past couple of weeks, and they will decide if the patient qualifies to be listed or if they don't or they don't qualify. At times, you may not qualify at that time, but provided there are certain tests that could be done or certain things that can be accomplished, this could also change. It's not surprising to require more testing after this process is completed. Next slide. So waitlisting. So once you are told that you are on the waiting list, you could potentially be listed inactively, meaning that you are gaining time on that list, but you're not eligible for offers. So this happens when, let's say, you may have either a cancer that was recently treated or a cancer that was recently treated, but you now need to be cancer free for, let's say, a number of years. You don't want to lose time and then start from scratch, 5 years down the line or 3 years down the line. So we can at times list you, but list you inactively. About a third of the patients on the national waiting list can be inactive for one reason or another. Next slide. How does organ matching work? So let's say you're now on the list. How does this whole process actually work? So in the United States, the nation's transplant system is called the OPTN, or the Organ Procurement and Transplantation Network. It's managed by something called UNOS, United Network for Organ Sharing. And UNOS manages the waiting list, and they try to ensure that when the organs are distributed, this is done so equally, fairly, and using a transparent system. UNOS has a central computer network called UNET, and that connects all the organizations that help retrieve the organs and the transplant centers where the transplants happen. So when a transplant center sees a patient and feels that they are a good candidate, they'll enter their medical data into the UNOS computer system. And the computer system, as I mentioned earlier, links the organ procurement organizations, OPOs, with these transplant centers. When an OPO has an organ that is available, they will then enter the information of that potential donor into the computer system, and a match run of candidates is generated. And based on which person matches best with the potential kidney is how we come up with is what then leads to the transplant. Next slide. So there are many different factors which determine how it works on the waiting list. Your blood type matters. Certain blood types, patients with certain blood types will need to wait longer than others. Waiting time, meaning how long have you been on the list, matters. And your waiting time starts from the time you either started dialysis or when you were evaluated and your kidney function was less than 20%. How well does the donor and the recipient tissue match? How far is the potential patient from the hospital, from the donor hospital? What do we think would be the benefit to that particular patient? Has that person been a prior living donor? So anyone who's in the past given a kidney to someone else, and unfortunately then led to develop kidney failure down the line, which is not a common occurrence at all. But if you have been a prior donor, you get priority points. Or if you're younger, if you're a pediatric patient, you also get priority points. Next slide. So the waiting time for a deceased donor transplant, as I explained to you, depends on multiple factors, but one major factor is the blood type. And this is very region specific. And this changes whether you're in the south versus in the northeast, etc. But just to give you an example, in our region, the waiting time for blood group O and B is roughly 5 years. For blood group A and AB, it's closer to 2 to 3 years. On average, the wait time is 3 to 5 years. Next slide. Waitlisting at multiple centers. So while there is one national waiting list, but it's important for the patients to understand that organs are distributed locally and regionally first. So what that means is that if you are listed at multiple transplant centers all over, in different parts of the country, since when an organ becomes available, it will go to the local people first, or the local list of patients. There is a possibility that you may get a kidney sooner by being listed at a different transplant center in a different area compared to where you live. However, it's important also to know that if you are listed in multiple transplant centers, but they all fall under the same OPO, then you're not necessarily increasing your chance of getting an organ, because the organs are going to be distributed to everyone sort of equally in that area. It's not transplant center specific, and your insurance may not cover costs at multiple centers, so that's something you do need to know beforehand. Also, you should know if you will have the finances to cover your cost of staying close to a transplant center. These are all things that you may know some of these answers before you come in to be evaluated, but our social worker and the financial people will also help you figure this out. How does the on-call process work? So what I mean by that, next slide, is when a kidney does become available to be transplanted, you may be called in, but you may be called in along with some other people. So there's usually what the target patient, the person that we think is most likely to get the transplant. But if for some reason that patient does not go through for, maybe had a recent illness, etc., by the time they come in, then we always bring in some backups. So don't be disheartened if this happens. But at times you may be discharged without a transplant, and at times, the quality of the organ may be such that, by the time the organ is, we get all the information, we may realize that it's just not good enough, and then the team may decide not to transplant you. I'm going to now go over, let Macy go through the next few slides, which are going to be focused on the living donation process. Here's Macy.
Hi, I'm going to talk with you about living donation basics. So next slide. About 1 in 4 people are willing to donate a kidney to someone if they knew someone in need. The National Kidney Foundation did a survey of this several years ago. And so what you need to know are that there are 2 types of living donation. The first type of living donation is directed donation. This is when you would donate a kidney to someone that you know. You can be related to them biologically or unrelated to them biologically, but it's definitely donating a kidney to someone that you know or have directed your organ to. There's also non-directed donation, which we kind of term altruistic donation. And this is when someone, a good Samaritan, comes out of the blue and says, I would like to donate my kidney to someone who needs it. You don't have to be the same blood type or be a match with someone to actually donate. If you have a healthy and willing donor, the transplant team will be able to likely find a way to make a transplant happen. So there are several benefits to living donation. And as we've discussed earlier, transplantation is a ideal treatment option for those suffering from end-stage renal disease, and that the half-life of a living donor kidney transplant is longer than that of a deceased donor transplant. So with living donation, there's less of a wait time. The kidneys do work better and last longer than a deceased donor kidney. However, if a donor were to develop kidney failure, which there is a very small risk of a living donor developing kidney failure, as Fiza mentioned earlier, they do have a priority on the national wait list. There's prior living donor priority points for that. Living donation also can shorten the wait list time for others. When you have 2 patients on dialysis and they're both waiting for a deceased donor kidney, if one of those patients is able to find a living donor, that opens up a spot for a kidney for that other patient. Living donation surgery is also a scheduled procedure. So this gives us time to plan and to think through scheduling issues that can often not happen when you are called in at the last minute because the kidney became available to you. Living donation also offers the opportunity for preemptive transplantation. So you could even be in the early stages of learning about how to get a transplant and being evaluated for that need, while also at the same time reaching out, looking out to find a living donor. So you would not have to be on dialysis at all. That is a possibility. The cost of the living donor's medical care for the evaluation and the screening, as well as the surgery, is covered by the recipient's healthcare insurance or Medicare. I do want to make it very clear that time off from work and travel expenses, lodging, and other incidental expenses are not covered by Medicare, but there are resources available to help you in this regard. Please contact the National Living Donation Assistance Center for this type of support. The website is www.naldac.org, www.nldac.org. As we mentioned earlier, if you don't have the same blood type as someone you want to donate to or that could be your donor, the transplant team still can likely find a way to make your transplant happen. That is through paired donation. Paired donation means that we exchange organs with another donor or recipient pair in order to make a better match. This can happen between 2 or more pairs and can start chains even from a single donor. The goal of paired donation is to find the best possible kidney for each recipient. After you find a living donor and the living donor decides to make that decision, recovery after living donation is not that bad. Most of our donors spend about 2 days in the hospital and are fully recovered after about 4 to 6 weeks after their donation surgery. Most donors return to work in as little as 2 weeks after donation, as long as they don't have a manual labor job. There are situations where if you are a construction worker and you have that, you probably will not be able to return to work in as little as 2 weeks. Living donors will require some temporary pain medications after donation. It is abdominal surgery. There are no dietary restrictions after donation, but in order to maintain a healthy life with one kidney, it is recommended that living donors continue to have a healthy, balanced diet. After the initial recovery period, there are no physical activity restrictions. So now, next slide. So now I'm going to talk with you about how to find a living donor. And there are several ways that you can identify individuals who might be willing to consider talking about living donation. First of all, you want to identify your social networks. And this starts with the people that you know, your family, your friends, your neighbors, your coworkers, your religious groups and organizations, your other recreational and social groups, any volunteer and charity groups, and people that you do hobbies with, your golfing buddies or your bowling friends, right? Identifying your social network. Then there's an opportunity to use media in order to help other people learn more about your situation and need for a kidney. You can start with a local newspaper. You can create community flyers. You can create bulletins that go into your church or volunteer charity groups. You can create emails to friends and families and listservs. You can start a blog about your own journey to find a kidney and your story. You can use Facebook. You can use a personal website. You can use Twitter and other social media sources in order to help you share your need with your larger social network about your need to find a kidney donor. If you do decide to do this, planning ahead is really important. Next slide, please. You definitely need to ask for some help, and you want to approach your group and community leaders about this ahead of time. It's not really good to just start doing this massive outreach with other organizations if you haven't kind of given them a heads up. So that's my advice. Then you want to brainstorm some of the most appropriate ways to reach the right people at the right time with the right method. So depending on the people you've identified in your social network, you might need to reach them in person. They might be better to be reached on the phone, or you may have a group of people that would benefit from you posting this on your Facebook page, for example. You do want to plan what you want to say in advance, and you want to make sure that people have a way to contact you in order to get tested or to receive more information about being a kidney donor. It's also very important that people know where your transplant center is and how to get in touch with them, because that is how the testing begins for you as a kidney transplant candidate for your living donor to contact the transplant center. Next slide, please. Just a couple of things about what you should do and what you cannot do when you try to find a living donor. You definitely want to introduce yourself. Honesty is the best policy. Use facts and be respectful. Use educational materials that may have been provided to you by your transplant program. There is information from the United Network for Organ Sharing about finding a living donor, a brand new resource online, and that is available to you as well. A couple of things to keep in mind. You cannot absolutely pressure someone to be a living donor. You cannot use force. You can't bribe someone, and you certainly cannot pay someone. Those activities are 100% against the law. Next slide, please.
So just going to talk a little bit about the transplant surgery itself. What you see on the screen just gives you an example. What you see at the top, those two brown bean-shaped structures are the person's or the patient's own kidneys or the deceased kidneys. And what you see lower down, the slightly healthier, larger appearing bean-shaped structure is the transplanted kidney. So transplanted kidneys are put in sort of in the lower part of your abdomen, and that kidney comes with some of its own, it comes with its own draining tube known as a ureter, and it does come with its own vein, and artery, and these are then connected to the recipient's or the patient's vein and artery. The draining tube known as the ureter is put in directly into the bladder. Your old kidneys are generally left in place. This is a common question we get asked. Well, what happens to my own kidneys? We leave them alone. There is no reason to do additional major surgery to remove them. If there is concern, however, for a lot of cysts or masses in the kidney or recurrent or problems with a lot of infections in the kidneys, etc., there may be certain reasons why we may choose to remove them. But in general, those kidneys are generally left alone and they don't cause any problems. Next slide. You will be on a number of medications after transplant, the most important of them being the anti-rejection medications or the immunosuppressive medications. Normally, your immune system protects your body from anything that we consider foreign, like a virus or a bacteria. Now, this kidney transplant is also something that's foreign to your body. So in order to prevent your immune system from rejecting this kidney, we put you on, or we start you on immunosuppressive medications. These medications are for the rest of your life. You will also be put on some antibiotics and antivirus medications for some months after the transplant, and that is to protect you against infections. You may require some medications to help prevent heartburn. Often this is temporary, just like the antibiotics and antivirals that I mentioned. Blood pressure medications may still be needed. In some cases, you may require more medications, other times less. Diabetes medications also continue. You will also likely require cholesterol medications. And then pain medications are temporary. Next slide. So on average, patients who undergo transplant stay in the hospital anywhere from 3 to 7 days. With deceased donor transplants, oftentimes the stay can be it can be closer to 4 to 7 days, a little less with living donor surgery. Especially in particular deceased donor transplants, at times the kidney transplant doesn't work right away or works slowly. There may be issues with your potassium climbing up after the transplant. So you may end up requiring some dialysis sessions. This should not necessarily alarm you. Because up to a third of the patients, or slightly less than a third of the patients, do require some dialysis after transplant. So if if the kidney isn't working right away, it's taking a little time to open up, this may be something that may keep you in the hospital a little longer. Next slide. Post-transplant care. So once you are done with the transplant and you leave the hospital, you will be assigned a nurse coordinator, and that coordinator will be someone that you will hear from very often, and also someone that you need to stay in touch with. Make sure you will be given appointments to follow up on, initially more often, maybe even once a week, and then this will be tapered off. You will be required to undergo blood tests and take your medication and come in for blood tests frequently, a couple of times a week initially, and then tapers down within a short period of time. And you'll be closely managed by the transplant nephrologist. There is a webinar that was done not too long ago that can also provide you more information on this, and you can see the link there. Very important, patients who are of reproductive age do need to discuss plans for birth control and pregnancy during this time. It's important to know that immunosuppressive medications can lead to birth defects. So if we generally tell our patients to wait at least a year before they consider getting pregnant, and even before they decide to start trying to conceive, there are medication changes that need to be made. Next slide. Certain important points to remember: just stay in touch with your transplant team. Keep us up to date. If there are any changes to your health or medical history, please do inform us. And your blood samples are generally sent to the transplant center either every month or every 3 months. And if there is any confusion, just reach out to your coordinator and they'll be able to explain this better to you or make sure this is done. Next slide.
So We'll close this with where to find some more reliable information about kidney transplantation. The American Kidney Fund has a redesigned transplant section on its website. You can access that at www.kidneyfund.org/transplant. As I mentioned previously, the United Network for Organ Sharing also has a wonderful new resource, the Kidney Transplant Learning Center. In addition to that, there is information about how to find a living donor and information about living donation, specifically on the UNOS website. In addition, the American Society of Transplantation has a lot of information about transplantation, about living donation, and about the whole field of organ donation and transplantation. Please check that website out as well. They are at www.myast.org.
Next slide, there's some information about next month's seminar, which Melanie will go over. And thank you for listening to us.
Well, thank you again so much, Dr. Henderson and Dr. Nachby, for joining us and leading such an excellent webinar. As a reminder, the slides that were used during this presentation today will be posted to our website once the recording is made available. So you can check back for that at kidneyfund.org/webinars for this information to be posted within the week. At this time, I'd like to ask both of you some questions that we've received over the course of the webinar. And we have several questions, and we will try to get to all of them. If we don't, what we'll do is have Dr. Nachby, Dr. Henderson respond offline, and then we'll post the questions and their answers to them on our website in case everybody or several people may have had the same question. So see, we have a lot. So let's see, I'll just get right to it. So we have one question from an audience member. It says, the list is 10 years long in Northern California, so we are on dialysis an average of 8 years. What do you recommend for this?
Thank you, Melanie. So as I explained during the webinar, hi, did you catch that? Okay. So as I explained in the webinar, yes, there's a huge discrepancy in the demand and supply. So there's the waiting times do vary in multiple places. I think if the only way around this is, if you have a potential donor. So again, it's important. A lot of patients often do not talk to people or spread the word, and you'd be surprised at we get surprised all the time. We have church members and people, friends of friends of friends who show up and are interested. So spreading the word is important. I think all the more, you need to invest some energy towards sort of getting the word out there. And the other thing is, as I mentioned before, getting listed at multiple transplant centers. And again, this resource that we mentioned, the SRTR website, will be able to help to some extent to understand, especially the larger volume centers, etc. Maybe something to consider. Waiting times in different regions of the country vary. So that truly is the best that we have right now. Thank you.
Thank you for that. That's a good segue into another question that we received. It says, many insurance companies only allow dual listing. How can we get listed in more locations?
So that is, I unfortunately do not have a great solution to that. I think definitely considering a transplant center that is close to you and what we could call a reasonable volume kind of center would be the best bet, and then definitely considering another transplant center which comes under a different OPO would be something to consider. Unfortunately, there's no way around this. Insurance companies, if they do not approve or do not allow you to be listed, then we are unfortunately stuck. And again, comes to the possibility of a living donor. That's the one thing that could make things move faster. Thanks.
Thank you. Another question. I've been told that kidney pancreas transplants have less of a wait time than just kidney transplants. Why is that?
So there are, so pancreas transplants, for the most part, are transplants that are offered to patients who have type 1 diabetes
So patients who are completely dependent on insulin, and even then, not everyone with type 1 diabetes needs a pancreas transplant. Patients who have complications and who have had diabetes for a long time with a lot of complications from patients who have, let's say, where they have sorry, I'm blanking out for a second here, but patients who have hypoglycemic unawareness, patients who do not dangerously low glucose levels, who oftentimes will pass out or danger to themselves and society. Those are the kind of patients who are considered for a pancreas transplant. It is a pretty invasive surgery. It's a more complicated surgery than kidney transplant alone, and there are fewer patients who need a pancreas transplant. Hence, the list is smaller, and a transplant happens sooner. But not everyone with diabetes qualifies for a pancreas transplant because not everyone will gain any sort of advantage by getting a pancreas transplant unless you have a pretty severe disease.
Okay, thank you. Another question, is there a set number of blood tests done during an evaluation, or does it vary?
So generally, it's, I didn't go into this in detail, but generally the kind of blood tests that are needed are fairly standard. I can't say for sure if certain transplant centers don't do some extra tests, but it's a list of tests. We're not talking about just a few. It's definitely a number of tests because we're trying to also see if you have had prior exposures to certain infections, whether the vaccinations you have received in the past work. Do you need to be revaccinated prior to transplant? Your liver function is tested, your blood counts are tested. So there is a long list of tests that are done, but I don't think there is a set criteria. However, that does vary a little bit amongst different centers.
Okay, thank you. Another question, could transplanting an organ of a drug user cause the recipient of the organ to feel addicted to the drugs they used or experience some residual effects?
Not at all. Not at all. I think this is a little bit of a myth, which a lot of, which some people think is true, but there's really no truth to this at all. There should not be any concern about this if you do get a kidney from someone who had history of drug use in the past.
Okay, thank you. You mentioned longer time on hemodialysis equals higher risk of death. What about peritoneal dialysis?
Again, good question. I think most of the data that is out there, most of the patients who have been studied have been in-center hemodialysis patients, just because the number of patients on peritoneal dialysis, on home dialysis are just the smaller numbers out there. I think patients with peritoneal dialysis generally fare better than patients who are on hemodialysis. But when we do refer to, or when we talk about high mortality, in general, these are the patients, the data that we're using are from patients who are undergoing regular in-center hemodialysis.
Okay, thank you. We don't have a lot of time, but I'll try to get through the questions that we have remaining quickly. One question, maybe I'll just do them together. How long is too long on dialysis? And the increased risk of donors alive or deceased? And as far as deceased donors, how would you know their risk behaviors?
So I think the first part of the question had to do with how long is too long on dialysis. So generally what we tell patients is ideally, well, either no dialysis or less than 2 years. When the time on dialysis starts increasing more than 2 years is when the studies have shown that there's higher risk of comorbidities or complications. I didn't quite catch the second part of the question. If you don't mind repeating that.
Okay, it says, as far as deceased donors, how would you know their risk behaviors? I think it might be kind of asking what kind of lifestyle that they have, or I think that's all that we have, but that's okay. What I'm reading into it.
I think I understand now. So when a donor becomes available for transplant at a hospital, let's say someone who wanted to be a donor or their family wishes for them to donate, the OPO, the Organ Procurement Organization, has a team that goes and evaluates and looks into all the risk factors. That is how, the certain patients land, certain donors are on the high infectious risk list, patients who we had concerns about. Generally, patients on the standard list are patients who have been, these were people or donors who were evaluated and felt not to be at high risk for any of the kind of behavior that we talked about.
Okay, and this have to be our last question, but pretty interesting. Could someone be restricted from getting a transplant for health or other reasons, even if they have a willing living donor?
Absolutely. Unfortunately, if you are not healthy enough to receive a transplant, even if you have a willing donor step forward, we don't let that happen. There are opportunities if someone does have a directed donation in mind and the recipient is unable to receive, that donor still could enter a paired kidney donation situation where they could give their kidney to someone else on the list.
Okay, thank you so much. We'll have to leave it here. Unfortunately, we ran out of time, but the other questions that we have, we will have them answered and posted on our website. So thank you again so much, Dr. Henderson and Dr. Naqvi. Just as a note, our next webinar will be held on May 20th from 1 to 2 p.m. Eastern Time, and we will discuss depression and how it relates to kidney disease. Registration for that is now available, so check back at kidneyfund.org/webinars for more information and to register. When this webinar closes, please do not close your browser window. You may see a pop-up saying that the webinar has ended. Please close that pop-up and proceed to the webinar evaluation survey. Your honest feedback will help us make our webinar program the best that it can be. So thank you again so much, everyone, for joining us today.
Thank you.
Thank you.
Thank you. Bye-bye.